Well, thank you guys for coming inside on what I think is a pretty afternoon. I was speaking just briefly to Terlisa about this, and I feel like I owe you a disclaimer before I start. I don't have breast cancer or metastatic breast cancer, but I've heard a lot of stories, and I've had a lot of training in mental health and in cancer centers, but I get that you're going through something unique, and I get that it can be different when you hear from somebody who has something similar to it versus not. So out of respect for y'all and what you're going through, I just wanted to put that out there. And again, thank you for coming even so. And as we go through this and I try to answer questions, if someone in the group has an answer or can help solve or manage a problem, please do speak up, because I think that just like in the introduction, I have a lot to learn from people I work with. I mean, I think I have a lot to offer them, but it's a collaborative approach, especially when things get super complicated, like in stage 4. Okay, so this is the disclaimer beyond what I just said, which is that I am a psychiatrist. I'm not a hematologist or surgeon or radiation oncologist. I'm a psychiatrist, but I've been listening and working with people who have cancer for more years than I'm going to specify right now. And this is where I've been. As mentioned in the introduction, I was in North Carolina and then Philadelphia, which is where the pink balloons are for the October month celebrations. Seattle for a bit, where I started my psychiatry work in a cancer center. And then this is the Botanical Gardens in Atlanta. Atlanta's actually a pretty cool city if you haven't been there, and please stop by our Botanical Gardens if you get a chance to go to Atlanta. Okay, so I was just in the exhibit hall, and the Don't Ignore Stage 4 booth is up, and there are bumper stickers and cards. And I think what's terribly important to remember is what we heard this morning about cancer being a very different experience depending on where you are with breast cancer, and to get connected with the right resource. But there are a lot of people, and as somebody said earlier this morning, they're kind of sad that the meeting participation is growing, because that means there's more breast cancer to deal with. Of course, we can also look at it like more people are recognizing the need to connect and problem solve together, which is how I'm going to hold on to framing it with everybody here together. There's also another group, don't forget about. There's the group of men. So just when you think you're a group that don't forget about stage 4, there's another group. And psychologically, that can be really helpful because we can get really stuck in where we are. And if we can use that, relative piece. I have a number of people that come in to see me, and they sit in the lobby or the waiting room at the cancer center, and you see who's in a wheelchair, who's in a mask, or who's on oxygen. And sometimes that helps. Don't let it take away for a second how hard it is to manage what you have, but sometimes it helps to recognize that things are relative, and that situations can really be more complicated. Okay, so the good news and the bad news, and we'll try to focus on stage 4 and metastatic disease, is that you've been here maybe for a minute. Now, that's not true of everybody. Some people at diagnosis are diagnosed at stage 4, and that is especially if we're talking about a young person, and we can speak to that too. But more often what I hear is that people had a diagnosis, they get treated, and things recur, and then we deal with a stage 4. Not for everybody. And that's where this good news, bad news plays in. Like, you've made a plan before. You've met a medical team before. You know how to manage a medication list. You know how to get some attention, like in a big cancer center. That matters. That's a skill, to be able to tap into the right nurse or the right call center or the right scheduler. And you recognize that you can settle down your emotional brain once you have a plan in place. And at the very least, you know where the bathroom is. I mean, I just can't tell you how many people, it's just like, I don't even know where to go to the bathroom. And that's distressing, right? Like, that's like, the unknown, not just where the bathroom is, but the sense of not even knowing where the bathroom is. Okay, even if stage 4, even if metastatic, the plan still goes back to the same thing that is stage 1 or stage 2. You got to make a plan. And you're a survivor, and as some people correct me, a thriver from day one of diagnosis. And regardless of where you are, you need a plan. So these links, or if you Google up Survivorship Care Plan, Journey Forward, OncoLink out of PEN, or ASCO, will walk you through it. I mean, if maybe you kind of like had a person managing it for you before, or kind of got by with a lot of chaos the first time, it just is going to settle your emotional brain to have a plan. And having stage 4 still means you make a plan. It doesn't mean throw in the towel. It doesn't mean forget it. It means you make a plan because you're here, right? Like, we're here. But it is a harsh reality check. It's like right up in your face. And it can be around it not being fair. You didn't ask for it. You did everything right. You went through treatment just like they said, and now it's back. Or you've been exercising and eating well, and now you have this thing, this stage 4 thing. Like, it's not fair. My friend had 1, and now why do I have 4? It's not fair that it's not going away. Our culture, our medical establishments, the way that we think about dealing with problems is you deal and they go away. And this is not that. This is a thing that's here, and it stays. And that can feel completely overwhelming and frustrating. The picture, does anybody know what the picture is from? It's Maleficent. It's Angelina Jolie and her friend that changes back and forth from a boy to a bird and a bird to a boy. And so why do I have that there? No, it's not about an angel and going to heaven, although sometimes this is part of like what happens, right? This is the harsh reality check of mortality, and recognizing just up in your face, like, the end of life is part of life. But that's not what I meant by the picture. I like the picture because Angelina Jolie in the movie, Maleficent in the movie, had a harsh reality check of this boy that she loved betraying her in the most wicked of ways. You remember he cut off her wings? And then it wasn't until she found, the true love, the caring for the princess of sorts, that her wings grew back. And so, she had this harsh reality check that things weren't fair and that people could be really awful and situations could be insanely difficult. I mean, the world turned into thorns. But there was something bright and beautiful that she was able to tap into. And so even with a harsh reality check, where can we find something that's a little bit brighter and a little more beautiful? I do hear a lot in my practice, especially for people that have done a lot of thinking and have gotten to a place of acceptance, that the problem is not about dying. The problem is about the process of dying, and what does that mean, and what does it feel like, and then what does it mean for my family. And so we'll talk about those things as we go along. One other thought on the picture, some of what keeps me going is this little bird boy person is there. He sort of sticks around, and whoever sticks with you is a bird or a cat or a female or a female male or whatever, is that sometimes they stick around. It's like this group, like people are here and they stick together, and I find that a beautiful thing in the midst of this harsh reality check. Okay, so it helps our emotional brains to move away from the harsh reality check emotion and to switch into a practical gear. Practical gears are a little bit easier in a way to take care of. And this is practical stuff that really we should have talking in general sessions for everybody, whether you have a medical problem or not, whether you have advanced disease or not, but everybody should do their advanced directives. That means you've appointed a healthcare power of attorney, you've thought about a living will and what your wishes are if you couldn't speak for yourself, organ donation if we were all in a car accident. The 5 Wishes is a website that walks you through it if you're not medically used to walking through it. Healthcare power of attorney is what are those letters. And the reason you do this from a psychological perspective is because then you can be reassured it's done, right? It's written, it's all sorted, so when inevitably end-of-life stuff pops into your head, you're like, wait a second, I've got a plan. This is organized, this is written down, it's in the cabinet, it's in the file drawer, it's put away but it's done. It's not something I have to noodle on all day long. I mean, obviously, you're not going to leave it on the kitchen counter unless you're looking for an argument with your family. And then the other thing that's very practical and very important, especially if you've gotten treatment in one center and it may not be a specialty center for managing metastatic disease, that you start to think about who's going to be your team. Like who's going to help you? Who do you trust? Who can you communicate with that can help you manage what's a little maybe more complicated than a different stage? The second opinion issue. So the more opinions you get, what do you have? Opinions. And so you have to be a little bit careful about those second opinions because doctors don't agree. I mean, who's had an experience where doctors have different ideas about how to manage, right? And that is even more nerve-wracking because now you've got this nerve-wracking diagnosis and you don't have a firm plan that everybody agrees on. So I think when you look for a second opinion, maybe 2 second opinions, but stop, because doctor shopping isn't going to help the anxiety or make it go away. When you look for the second opinion, you look for somebody who has expertise in what you have, who spends their time and energy taking care of what you've got. And you take with you to that second opinion what you have had done and specific questions you have for that person. Okay, so these pictures I think are kind of cool and arty, and maybe they'd be in a Greenwich Village loft if that's where I lived, but I don't. But they are pictures, drawings of brain cells. So this is the emotional management. We're trying to manage these brain cells, right? And these brain cells, even though it's not the exact part of the brain where you have emotion, they generate a pile of emotion, a lot of which kind of hovers in the grief domain. Grief is loss, grief is sadness, grief is I thought it was this and it's gone, or I thought it was this and I don't have that anymore. And that can be whether it was your health, whether it was an idea you had about your lifespan, whether it was an idea you had for 10 years, 20 years, whatever long time frame you might have had in your mind. With a diagnosis, sometimes that you grieve what your ideas were, you grieve what your plans were. There's this writing in the literature with death and dying that's now been taken over for any kind of grief about the 5 stages, that you work through the 5 stages, maybe not in order. Elizabeth Kubler-Ross, she really did write the book on death and dying, but I think sometimes people use it to help them frame what their experiences are, their emotional experiences when they go through a major life crisis, which can be reasonable so long as you don't hold on to it too tightly, so long as it's helpful as a framework for what your brain cells are dealing with. And I think at the sort of core of it all is this issue of time. So we don't know. That's the version of a crystal ball, and everybody wants to ask their oncologist, and none of the oncologists want to say because, shoot, they can't, right? Like, people are defying odds, and they're making the physicians go, huh? Like, you're here? Oh my, that's awesome, but it's like, we don't know, right? And then sometimes, terrible, tragic things come up, complications of treatment, and that wasn't what we planned on either. So we just don't have a crystal ball to answer that question of time. And, you can feel sometimes like that clock is ticking, the little timer watch picture there. And why it matters so terribly much is because it's precious. That's the ring. Who's a Lord of the Rings fan in here? The precious ring, this powerful ring, like the little gremlin, what's his name? Schmeagol, he calls it the precious, my precious. And he clamors and craves and everything about this ring. And because he just feels so intense, such an intense connection to this ring, and it has a lot of power, and we won't go into that. But the same is true of time, right? This is what we all have in limited supply, but it's different when you have a diagnosis and you really have to think about how you're going to use your time. So what do we do with all of that? Let's switch back into practical mode for a second. Having a team is critical. There's a medical team that's on the left-hand side here in a little bit of blue. And just remember, there are a lot of different doctors. So in our pain management process, which comes up quite a bit in metastatic disease, you have your oncologist who may be well trained in managing pain. There are also doctors who specialize in physical medicine and rehab, which usually refer to physical therapy. You have anesthesia doctors that burn, cut, zap, inject nerves in the nervous system. palliative care doctors who are not just for hospice, but they are experts in managing opiates. So if you're on an opiate regimen, knowing a palliative care and hospice doctor. And then the integrative naturopathic guys, so long as they're kind of like woven into your plan of care with your oncologist. And then my group of people in mental health. The team, I just really am delighted and inspired by the people that I get to work with that are in the social work, in nutrition, and spiritual health. They just provide so much to the care, as well as the physical therapists, occupational therapists, and speech therapists. I see a number of people who have head and neck cancers, and the speech therapist people are amazing. Okay, but then there's also you. You're part of the team. So one of the things I try to stop people on when they come in and say, well, you put me on this drug, or you're going to put me on this drug. I'm like, wait. We're going to make a decision together, and you're part of this team. So I can't be putting you on anything. We need to do this together. Do you know about this lady? She's Rosie the Riveter. Rosie the Riveter, and she is the symbol of World War II and the strength of women, and women contributing to the effort to defeat the Nazis. She died this last year, but she's in her 90s or something, and she was this poster child for women's strength, I think. The other one is your team. Very, very carefully defining who's on your team, maybe that's outside of the medical world. And it may not be the person you expected. It may not be the person that you hoped. There may be a lot of sadness or grief with regards to people that aren't able to contribute in a way you'd like with your symptom management. But looking for those that can step in is worth the energy and time you put into it. Okay, this is, as they said yesterday, the Lword, but it just can complicate so many things if it's not managed right away. And I'm probably telling the choir something they already know, preacher, choir thing. But if you can ripple this message out, into the greater world on Monday or whenever you know people, is if this is going to be part of what happens to you, looking to manage it right away up front, because down the road it can complicate your function day to day and your mindset too. Okay, and finding a good lymphedema specialist, a special therapist trained in lymphedema, is critical. Okay, I have these 2 slides just for a little medical blurb, medical education. Has anybody heard of the Karnovski scale? It's something that the oncologists are using to sort of figure out how people are doing with their function. And maybe it's helpful to know, where are you with your function? And it goes from this 100, which is the normal, no evidence of disease, and then trickles down to 0, where you're not here, and things in between. And so it gives you a sense of like, where am I functionally? Where is the disease or the symptom burden limiting me? And that it kind of matches up maybe with disease trajectory, but also what you want to talk to your oncologist about is if you're changing on that scale. And the other one is the ECOG scale, and that is 0 is fully active, so it's kind of like the reverse thing. So you want to make sure you know what your oncologist is talking about with the scales, not just the number. And then 5 is a score where people aren't living anymore. Okay. But regardless, do you want me to go back? Does the ECOG, it's Googleable as well. I'm not sure Googleable is a word. I think excuse me? Yes, it does. It stands for European Consortium Oncology Group. Oh, it's right underneath the scale. I owe you an answer to that. But if somebody Googles it up and tells everyone else, I welcome that. It's right here on my head. The Karnovski, You can see them okay-ish. Okay, but at the end of the day, what's the best medicine? Who's heard this before? Eat well and exercise. So in harsh terms, your mobility is related to an organ system. And so with your musculoskeletal system, the more mobile you are, the more you use it, the more that organ system continues to thrive. It's like if you were looking after your liver numbers or looking after your kidney numbers, like you want your organ systems to survive. And so using them, whether you're limited by your gait, which is walking, whether you're limited by your range of motion on one arm, how can the physical therapist help you move your musculoskeletal system so you keep it conditioned enough so that that organ system works for you, whether it's getting dressed, whether it's getting through the shower, and works for you in a way that doesn't hurt. It's tricky to let this be the best medicine because you have a short visit made with your oncologist, you have lots of prescriptions, you have lots of appointments, and it's fatiguing to manage it all. This has to be scheduled. It has to be like an appointment. It has to be on the daily agenda at a specific time because if it's not, it falls off to the wayside. Okay, and then there's the supplements. I think something that happens is that you get a more difficult set of medical information or news, and that makes us all feel like, hurry, do something, take something, go somewhere, meet somebody, fix it, right? That urgency, the anxiety that comes up around dealing with it. And so you start looking for what's out there to fix it. The pill bottles or the supplements, the fish oils forever, we're trying to plug them in psychiatry and general medicine and cardiology and arthritis. The probiotics get a lot of attention right now. We're just starting to learn about the gut biome and how that creates an inflammatory response in your whole body. But at the end of the day, unless it's a slam dunk, like we have science that replacing your vitamin D if you're deficient is good for your bones, are you wasting your money on the supplements? Maybe. Could you be eating the food that the supplements are derived from and get more benefit? Could you be eating the fish? Could you be eating Greek yogurt? Could you be having fermented pickles, chilled pickles, and have the probiotics that way? And then the flour. Does anybody know the flour? It's not about being in nature. It's the poppy, yeah. So the opiates. So this is just huge. When you have metastatic disease, when you have cancer, you often get, as I call it, sort of a pass on the opiates. Like you'll hear about them on the news. That doesn't apply to you. And in medicine, it doesn't apply either. Like if you have a cancer diagnosis, I don't have to check this physician drug monitoring program because it's an exception. So you're going to get prescriptions because people want to help. The oncology teams want to help. The question is that prescription helping you? So is the morphine or the oxycodone or the fentanyl patch or what have you, is it helping you get through your day or is it slowing you down? Is it helping you interact with your family or do your work or is it fogging your brain? And so you have to look at the opiates as, are they really, really helping you function or are they kind of getting in the way, and how can we balance that out? I mean, sometimes we add a second medicine to help balance it out because the goal is not to be in pain. But there are a lot of ways to manage pain besides opiates. And it's not just smoking cannabis, which is the last plant. So this came up in the general session. In Georgia, it's legal to have THC, which is the psychoactive component of marijuana, THC oil, 5%. We have no idea where you can get it. We have no quality control measures, and we don't have any data about dosing it. We just don't know. And so you can go to California, you can go to Washington, you can use it legally, but we still don't know, like how much, what strain of the plant, what dosing schedule you should be on to get benefit. What we do need to be cautious of, just like with the opiates, is function. Does it really help you be a better you and use your time wisely? Or does it kind of get in the way and you're like smoking and out of it and somebody else is dealing with everything else at home? You know, we got to figure that out. Lots of people tell me it helps with nausea. Lots of people tell me it helps with pain. People who are grandmas, people who are 20-something, you know, skateboarders. Anyways, I mean, everything in between. Like marijuana is just all the rage right now, but it's something we have to do thoughtfully, just like we do with our prescriptions, which we're trying to do thoughtfully. Okay, so the talk is supposed to be about depression and anxiety after diagnosis. Oh my gosh, I gotta talk a lot faster. Cancer distress, this is a real thing. The National Comprehensive Cancer Network defines distress as this unpleasant feeling and emotion. This is not something in psychiatry we focus on as much, but something that we begin to identify what's going on for the person with cancer. There's a distress thermometer. It's supposed to be in every cancer center. It's supposed to be a screening tool that we use to catch people. It's 0 to 10. And then it's everything psychosocial along with the physical that people are dealing with. Adjustment disorder is when we get into the mental health problems, and that's where you get a diagnosis, and we think about talking therapy to help manage adjustment disorders. Generalized anxiety disorder. This is a psychiatric diagnosis. Some people come into cancer with, some people develop through cancer. We treat it with medication, but also with talking therapy. You can see down there at the bottom, it's more common for people who have a cancer diagnosis, and some of the numbers that come out, they're all over the map depending on what kind of cancer you have, what stage of cancer you have in terms of anxiety or depressive disorders. But this is sort of a general idea that you have an increased rate of anxiety and depressive disorders in cancer. And this is clinical depression. This is not I'm bummed. This is not I cry for 5 minutes, every morning. This is not I'm kind of tired in the evening. I don't feel like having dinner. This is like deep, dark, nothing is good, I feel hopeless, I feel like a bad, worthless person, and even with thoughts of suicide. So this is a mental health problem. This is you not your regular self. And recognizing that there are treatments is what's critical, because you don't have to stay with this medical problem in addition to the other ones. This is a medical problem we can treat. Okay, so red flags. Alert, alert. If you or a family member or a friend or a colleague, any of these red flags, this is where you get help. And try not to say it like you need a shrink. More like, this is really stressful. Things have seemed different recently. I think things could be better. Let's think about getting you some help. We do have medications. You don't have to take a medicine to treat an anxiety or depressive disorder, but just like if you had asthma, you'd use an inhaler. If you had diabetes, you'd use insulin. These are tools to help manage medical problems. Unfortunately, they're not perfect. They do take time to work. They do take several weeks sometimes at the right dose to work. You can't just take it as needed to treat depression. Here are some of the examples. What comes up quite a lot in the cancer population are the ones that are SNRIs, because those are the ones that help with pain. If you've ever had a pain syndrome, doctors have probably offered you Elavil, amitriptyline, Pamelar, which is nortriptyline, and these are the newer ones, Effexor, venlafaxine, and Cymbalta, which is duloxetine. We like them because they're not opiate related, meaning they don't have the side effect profile of the opiates, but they do have their own side effect profile, and we got to make sure we don't make people worse. We do something that's helpful. Remeron is the sleep and appetite stimulant, mirtazapine, and so if you've ever had trouble with sleeping or low appetite in the cancer center, we'll use mirtazapine. It can cause dry mouth. It can cause morning fatigue, and so we have to be careful with those things. And then Wellbutrin is bupropion, which some people use for smoking cessation. Okay, here are your anxiety medicines. They've got the same cautions as the opiates. So opiates are sedative hypnotics in a way. Benzos are the sedative hypnotics. Those are the ones that quiet us down right away. The problem is they quiet us down right away, and sometimes people want to stay that way all the time. And so it's very understandable. Like when you're in a complete panic and you think you're going to die from a heart attack, or you're so short of breath, your head's spinning off your shoulders, it's understandable, and we will use them occasionally for that. But the other day, somebody said they were having a very sophisticated, highly educated person who's managed a lot of stress in her life, went into infusion and for her first one, and she'd actually noticed a medication error as she was walking to infusion, so that upped her anxiety. But she sat down in the chair and she couldn't breathe, and she was shaking, and palms were sweating, and they were like, it's okay. They accessed her report, gave her some IV lorazepam, which is Ativan. She says, the best I've ever felt. And I was like, whoa, wait, the best. But she recognized that it was for then. In that setting, at that moment, her nervous system was on high alert. She had to quiet things down or she couldn't have gotten through infusion. The SSRIs and the SNRIs we'll use for anxiety. So if your doctor gives you Lexapro and you say, I'm not depressed, it is first line for anxiety disorders as well. Buspar is an older drug that's sometimes helpful because it doesn't have the sedative hypnotic side effects of the benzos. And then your favorite Neurontin, which you've been offered for neuropathy, I'm sure at some point, gabapentin. We just have to be careful that gabapentin doesn't make you more sedated or coordination problems. Or we also follow your kidney numbers with gabapentin, because if your kidney numbers are up, the gabapentin in your system goes up. So you can get extra sedated with it. Okay, and then everybody's like, go talk to somebody. And you're like, wait a second, aren't I talking to you? No, the psychotherapy is like you sign up for weekly work. And you go in every single week, and your therapist hopefully guides you through a series of interventions to help treat anxiety and depressive disorders. There's lots of different therapists. Some psychiatrists do psychotherapy, licensed practicing counselors, marriage family therapists. And you got to know what they're doing. You can ask them, what kind of psychotherapy do you practice? Are we going to stay in the present? Are you going to help me be as functional as possible? And make sure they don't get stuck in a historical thing that happened to you that you feel you're at peace with, but they decide they want to dredge up. The insurance does cover psychotherapy. Most plans have a mental health component to it, so you can tap into that. But what a lot of people end up doing is, if they find a therapist they like that's in private practice, you pay and get reimbursed from your insurance company. It's tricky, it's expensive, and there are already a lot of medical bills. But if you're suffering, if your quality of life is impaired by your mood or your worry, then that's worth it. You're investing in yourself. You're taking care of yourself. Okay, helpful thoughts and behaviors. I may say the word helpful about 45 times a day, but it really is the best word, right? It's without judgment. It's without, hopefully irritation. It's like, okay, what's going to work for me? What's helpful for me? Adjusting definitions. So some people say, well, there's just no hope for me. I'm like, well, what does hope mean, right? I mean, does hope mean I'm going to be alive in 35 years? Or does hope mean like next week I might get to go up to this lake place and see a beautiful sunset and enjoy some cheese and crackers by the water? Like, that's something to look forward to. That's something to be hopeful about. Adjusting your expectation of what's beautiful. When you have changes in your hair, changes in your body, changes in how you're able to present yourself to people. Well, what is beauty? Where do you find it? Do you find it in a little bit of glitter? Do you find it in a beautiful scarf? Like, how do you define beauty, and being careful with your expectations? Setting limits. There are going to be things that remind you too much. There are going to be people that want to tell you what to do. And how can you carefully set your limits? Even if it's your mom. I got 5 minutes, Mom. And you watch. Okay. Mom, thanks for calling. Gotta go. And how do you set your limits so you can have enough left in your tank to get on with your day? Acknowledge and accept. We already talked about putting it away, the plan, putting it away. You have it tomorrow to look at. Allowing for compliments. It's a cognitive distortion. That means it's a thought that's not quite based in reality, to always discount the positive. So somebody gives you a compliment. Well, you look really nice today. And you're like, yeah, but I didn't brush my hair, and my lipstick is all wrong, and probably have food in my teeth. No. Thank you, right? You allow for the compliment. You let that stick. You let that sink in. You let that be good for you. And having a response. So have a line. There are going to be people you don't want to talk to about this. There are going to be people that want to bring it up. There are going to be people that, whether they're curious, they're morbidly curious, they're only trying to figure out what goes on with them, so they're going to ask you. But think about, as you go out into the world, what am I willing to share? How do I want to respond? I've heard the phrase cancer light. Has anybody else heard this phrase, cancer light? So you've been through your journey a while, or you get diagnosed with a stage 4, and then somebody is in a complete panic, unraveled about their DCIS or their stage 1 or their lumpectomy, and you're like, okay, I've been in the ICU 5 times. So, it's like figuring out how you can stay grounded and not lose your sense of purpose and your sense of well-being when reacting to somebody else, and not letting their energy disrupt yours. The angel of death, did anybody see this article in the New York Times? It came with the picture that's down below. This woman goes to parties, and she thinks that people are looking at her like the angel of death because she has stage 4 disease. I think her name is Kathy Baer from Durham. And all the things you would expect, like the, exhaustion of hang in there. I used to say hang in there to people, but I meant it in the nicest way. Like, you're doing a great job, you're hanging on, until a patient and a social worker said to me, stop it with the hang in there's, right? It's like I'm just on this branch and I'm about to fall 30 feet and you tell me to hang in there? Like, I don't want to hang here. And I was like, okay, no more hang in there's. But not everybody's going to get it right, We can't always find the perfect words to soothe or support our loved ones. So looking at the words and paying attention to which words kind of jostle you, can help you build up your defenses a bit. At the end of the article, she speaks to what worked for her. And as a psychiatrist and a therapist, it really made sense to me. She said that the woman that spoke to her that seemed to be most helpful said, I love you. I am here for you. You will not be left alone. I was like, spot on right there. I mean, you can't say that to everybody. People will be like, what? All this love. But, this idea that we're not going to be left, this idea that we matter, this idea that we'll be cared for, I think it, in our cores as human beings, kind of speaks to the panic, which is like the existential panic that happens when we think about end of life and we think about limited time. Cancer ABCs from surviving to thriving. It's again with the definition of beauty and hope. Thriving is being here. Thriving is up and out of bed. Thriving is sending an email to a friend or calling up somebody else to say, what did you think of that soccer game? Like, thriving is being out in your life even so. That's a win. That counts. Okay, and then obviously the support groups. Okay, more of the preaching, but what we got to do is get out into the world and let people know that care is there, let people know that groups can be helpful, that groups are not a bunch of complainers, that it's okay to go to groups with people in different stages. I totally get, and I have heard it from many people, I've heard it from people who are really struggling with scores, on those 2 scales that I showed you that are not looking prognostically like they'll survive long. And going to groups means you meet people that don't stay with us. You meet people that die. And that's a reality of going to the groups. A reality of coming here is that there's the memory wall, and there are those posters of women, half the story told, right out by the exhibit hall. It's a reality. But I think we can all work on framing it in a way like, oh my God, I got to meet her. And oh my God, what did she have to say? And oh my God, look at how she managed, right? Or look at what she did while she was here. And it's not easy, but we don't have a choice, because this is part of the reality we're living with, is figuring out how can we see what's beautiful about the people that are here, even if they're not here for as long as we'd like. Okay, the theme of the group matters. Not everybody wants to go to a breast cancer support group, and that's okay too. So long as you get up and get out. We're social beings. We're wired to be social, unless you have a type A personality disorder, which I don't think we do here, because usually you don't leave the house. That it works to be around other people. Pottery, pet therapy, training classes for your dog or cat, going to a part-time work. I've got patients who volunteer at the hospital. That works for them. That's okay. Other people that need to volunteer at the art museum don't need one more second of hospital. But finding a group that works for you. And then the leader. You can't be around a group of people that don't match up. If the leader is abrasive and problematic to you, then you got to think about finding another venue. I like Livestrong. Do you guys like Livestrong? Do we like Livestrong? Yeah? It's not all about Lance and the bike and everything. They've got a lot of wellness and stress management. They've got a lot of food. They'll send you an email every day. Anyways, I'm pleased with Livestrong. Okay. And then gratitude. This is where I circle back every single time, because for as much as I try and stay positive at work, I can get pretty dark and snitty and bitchy and yell, and I mean, it just happens. And I practice all this wellness stuff and stress management stuff, and I talk to people about mental health all day long, and then go figure at the end of the day. And what circles me back to being okay, what circles me back to feeling more grounded is journaling. And it doesn't work unless I do it, and I have to be really careful not to negatively journal. So there actually has been some studies that are done, people that write about all their problems. It makes things worse. I mean, think about what you're doing in your brain. You're repeating the stuff that's problematic. You're repeating the problems, as opposed to what can you look for that's actually serving you well, that's watering the seeds of wellness. So this picture right here, like, I think it's pretty cool to see the dance and the ribbon. They do it in the Olympics for the summer. Ribbon dance, ribbon gymnastics is what it is. And they married it in this picture with, I'm a warrior, my enemy is metastatic breast cancer, I will fight with strength, courage, and hope. Like, people can put together beautiful pictures, beautiful athletics, and poetry to go along with that. I am grateful that somebody is out there doing that work and putting it together. The granola. Well, first of all, they had good granola at breakfast this morning. Did y'all have that granola? It's got cranberries and almonds. Like, good granola is hard to beat. And it's like all whole grains. And if you're careful, you don't get the sugary stuff. Like, that's a beautiful thing in this world, is good granola. I mean, there's so much bad food out there that, like, when you run into good granola, it's like, you can write about that. That's something okay to write about, right? And so this last one is, I am here today, and today I would rather smile than cry. I think a few well-placed tears are totally reasonable and normal and expected for all of us. But with the reality check and this, like, harsh kind of management day-to-day of what is so hard with this medical process is figuring out a way that you are able to recognize you're here. We get stuck with the what ifs and the whens and the hows, but we're back here today. And so that can happen when you're in this, like, present state, when you're practicing gratitude, when you're writing in a journal, when you're saying to yourself, well, today worked, still here today, purple pen, nice journal. So if you leave here and do anything nice for yourself, let it be a nice paper journal and a good pen. And practice in the morning, putting 3 things in. Just see what happens. Okay, so those are my slides. I am happy to try and answer some questions. We have like 10, 15 minutes. Does anybody feel comfortable speaking up or want to ask a question? Yeah.
I think one of the things I struggle with most is living in the limbo.
Mm-hmm. Yeah.
And how to enjoy the time while it's good.
Yeah.
Especially, like, because I have young children. Like,
yeah.
Enjoy the time while it's good, but also not feel blindsided when it's
yeah.
not.
Yeah. Well, I know people that feel like if they keep thinking about all the worst case scenarios, catastrophizers, then they'll be better prepared for when they happen, right? And you could almost develop, a habit of doing that and a practice of doing that. But unfortunately, what that does is that solidifies that message in your head. We're all clever enough to get here. We're well educated enough to read up about resources and ask important questions. Things happen. Really, terrible things happen in a lot of different realms of life. Some of it depends on how you manage that philosophically, like where your beliefs stay. So people fall into the faith category, and they manage the uncertainties of life with their faith and prayer and spiritual practices. Some people fall into the category of, things happen, all kinds of things happen. And we could go through the list of things that happen outside of cancer, and that maybe settles you down a little bit because you recognize all things happen. Like, how much control do we really have, any of us? Like, whether you left your dog or your parrot or your kid or your partner or whatever, we all left them. I have no control over what's going on in Atlanta right now. None. I hope it goes well. but that is not making light of what you're saying so much as it's a tool I have, my oh well tool, to say there are just some things I can't control. And maybe it gives me a little bit of a leg up on the people that still think they have control, or they still think they can fix everything, or stay here forever, or don't recognize they're not here forever. Like, I recognize life is precious, and therefore I'm living more fully maybe than some people who don't. The other thing is to recognize that your awareness of bad things happen keeps you attentive. You go to talks and listen to what people who specialize in metastatic disease have to say. You recognize that I have to treat co-occurring problems, or this metastatic disease could get worse. So what are the co-occurring problems? Like if you're anemic, or if you've got obstructive sleep apnea, or if you have a substance use problem, like you get that stuff dealt with, because you know that your disease trajectory could be different if you don't manage the co-occurring problems, kind of like clinical depression or anxiety disorders. And yeah, at the end of all of that, it still does suck, like that you have it, and it's not anything anybody wants to be here dealing with. I didn't choose like a meeting, like we gotta be at Disney doing the like princess thing, but it's here. So we take a deep breath, we find our fellowship, we find our path, and manage as best we can. And sometimes I wish I had better answers, like how to make it go away. I honestly think some people come into my office and think I'm going to make it go away, or maybe that's my issue because I just want so desperately for it to go away, or think like, that would be the best therapeutic endeavor if I could make it go away. That will be a cool day. It'll come. It'll come. Okay, yeah. Mm-hmm. Oh, yeah.
But, yeah, so my doctors will prescribe things like Ativan and Ambien and fentanyl and Flexeril and all of these things, but nobody wants to give me a Xanax.
Yeah.
What is the is there like a crazy stigma with this one, like, and isn't it the same family? Like, what's going on? Like,
yeah. So
should I just deal with the panic attacks?
Well, okay, so there's a couple of things you brought up. One is some people, especially when they're young, have what I call a very messy workup experience. Like they don't get caught early because you're not supposed to have this when you're young. And so physicians will be like, oh, you've got irritable bowel, or, oh, you're fatigued. Maybe you shouldn't work 2 jobs. Like, so we miss things when people are young sometimes because we don't expect it in the young population. And that's on us to continue to do thoughtful histories, thoughtful physical exams. I think it can make it more difficult going through treatment if you've had a messy workup phase, because you really have to work again on your trust. You have to work on finding a medical team that you trust and collaborating with them, and then trusting yourself to report symptoms that are new and different, and not end up reporting every single little thing, and then you don't get the attention you need because you've reported every single little thing and they think that you're anxious. Okay, so the medication piece of things. Yes, there are a couple of red flag drugs, medications, that have a reputation and that physicians are going to go, huh, and pharmacists are going to go, huh, and maybe say a little more negative things than huh. And the medication in the class of benzodiazepines, sedative hypnotics, that has that reputation is Xanax, alprazolam. And it has that reputation because it's short acting and people feel it right away, and because they feel it right away they want more of it. It has that reputation because it has street value, which means you could take your supply and make a little money down there on the block. And it has that reputation because if somebody has an addictive disorder, it's like Xanax is on the list. So that's why Xanax has a reputation. There's some clinical thinking that longer-acting benzodiazepines are not as addictive. So if you get Klonopin, we're not worried because it's longer-acting. We don't have science to back that up, but we do it all the time. And the same is true of the opiates. So the opiate that gets the bad rap is Dilaudid, hydromorphone, because it's the most potent opiate. So if you've been in the hospital and gotten hydromorphone and not gotten itchy or vomited or psychotic, you may have had a really good experience with hydromorphone because it works. Like it just puts you in the happy place. The problem is it's lethal in overdose. It gets diverted, and it's lethal if it gets diverted and taken by somebody who doesn't know what they're doing. And it also has, street value, money down the block. So those two medications in particular get us wondering about addictive disorders. And we think with the opiates, if we give you a long-acting opiate, like a fentanyl patch, which actually is a lot of opiate every hour, it delivers medication. So it's a powerful medication. Or if we give you Oxycontin, which is long-acting, that you won't get addicted to it. I mean, of course, those problems could happen with those drugs too. I've had a patient who ate his fentanyl patch, like in his mouth. I was like, oh God, here we go. So, but that was complicated. The point of it is nobody wants you to panic, but they often don't have time to do the other things to keep you from panicking. So the things that keep you from panicking take longer to do. Whether you're going to meditate, whether you're going to practice your relaxation breathing, whether you're going to do some walking, whether you're going to do some audio headphones, whether you're going to wear your favorite sweater and socks, and that keeps you kind of like warm and grounded in the infusion chair. Like, there are a lot of things you can do to manage panic besides the medication. At the end of the day, if you're thumb wrestling and arguing with your oncology team about the medication, then you probably are due for a sit down to figure out how you can get all your pill bottles out of your house, bring them into clinic, clear it out, streamline, and be like, dude, we got to work together. If it's even 15 tablets a month, let's do the Xanax, but 15 tablets a month, and that helps me. But if you also are smoking pot, medically, it's not a safe combo. They're sedative hypnotics, right? They're brain quieting. So it's hard to expect the doctor to do it if you're also on other things that complicate prescribing Xanax.
Yeah, it didn't make sense to me because they gave me 120 Dilaudid at a time. But
yeah, we shouldn't be doing that either.
So that was cool, like from the same doctor, and I was like,
cool
what?
in not the greatest way.
It made no sense to me.
Well, so once they give you the Dilaudid, they shouldn't also give you the Xanax, and that's where he got into trouble. This is a funny thing in our system, and I'm thoughtful about it, and my partner in palliative care is thoughtful about it, but she will prescribe opiates all day long, and I don't prescribe any opiates because I don't do a physical exam. I do a mental status exam. I'll prescribe benzos all day long, and she won't do the benzos. But we have the same patients, and so we have to very thoughtfully look at their medication list and what they have. But we probably shouldn't be doing 120 Dilaudid tablets at a time. Yeah, that was not, Okay, so yes, question. Comment.
I'm a poetry and journal therapist, so that's something that people don't always know about.
Yes.
So I was really excited to hear about just that a lot of people prescribe journaling, but they don't know that there's just this whole world of, like certified journal therapists. And you can just buy, guided journaling, guided journals. I don't know if they're more common now that you can just buy a book that says like 99 things that make me happy. So they're good for people with like chemo brain or, when you're just too tired, because I've bought a ton of those, when I'm just too tired to just longhand or think of, gratitude things, which I used to do, and engage patients in that.
Yeah.
But just 3 things today that have to do with a topic. And it's almost like you're leaving your legacy behind, for your family to read about, oh, that made me happy. I liked, strawberry sundaes and all these other things. Another thing about, I just wanted to name, it finally came to me, about faith and journaling. A woman named Christina Baldwin. She's written some really great books. And they take more time to read, but you can just skip around. And there's this place, that I've done some training with the Center for Journal Therapy, and her name is Kay Adams, and she's the director. So those are some resources that you or
I think that's
anybody
great.
else can.
Thank you.
look
Journaling
into.
does not have to be a grammatically correct essay
Absolutely
format.
not.
You're going to be graded on it. No way.
No.
And there are lots of workbooks that will guide you through it, as opposed to having a blank piece of paper if that feels overwhelming. Absolutely.
Yeah. I mean, there's medical research from James Pennybaker out of the University of Texas at Austin that 30 years ago talked about lowering the heart rate and used for surgery and all this great stuff. So I don't want to take
all
up
this
time,
great stuff.
but
There's an art to it. There's a reason for talking about it. This is not a flash in the pan recommendation from a self-help magazine. And the same goes for some of the music therapy and the art therapy people do. These are folks who are master's levels training in how to use those modalities to help us feel better and help us be more functional, help our quality of life.
Right. The least one that's known is what I do, which is poetry and journaling.
Yeah.
So I just wanted to
Thank you.
say that. So.
Okay, guys, I think we're just about out of time. Unless you do have one more question, I'm happy to stay or come up and ask afterwards. Okay, yeah, for the group's benefit.
Also
thank
more
you.
of a comment. Thank you so much for your talk. It was really helpful. And my name is Christine, and I'm a metastatic breast cancer patient, have been for almost 3 years now. And I just wanted to talk a little bit about meditation. I think you touched on it. I took an intensive meditation 6-week class, and it was based on a book called Mindfulness-Based Cancer Recovery. And I do not consider myself a calm, non-anxious person. I thought I would never make it through this class, and that book was really, really, really helpful. It gave you really good tools to get started. You don't have to feel like you have to sit there for a half an hour and just try not to think of anything. It's almost impossible to do that, and this book kind of helps you, guides you through that. So I really highly recommend it, and I just think meditation and yoga, the journaling therapy, art therapy, it really does wonders for your anxiety and fears. So just wanted to say that. Thank you.
Definitely. We have more and more research science that mindfulness-based stress reduction, mindfulness-based meditation is a legitimate tool for taking care of people's mental well-being. So that's an excellent idea. All right, guys, have a wonderful afternoon. Thank you so much for coming.